So first of all, thanks Dr. Sanjeev Bhai, RSSDI Gujarat chapter, Dr. Shailesh Bhai for kind words of introduction. Thank you all the audience, Baroda team for RSSDI. I can acknowledge presence of my very close friend, very elder brother. Sir is here, Dr. Panikar Sahab, Dr. Rajiv Chawla, Dr. Shalini, and many more my friends. Well, I am going to talk the type 1 diabetes care, where we come from and where we are going. And this is very interesting. So I don't have any financial disclosure for it, but I am actively involved with many activities which is related to type 1. Recently, Government of India put me in a technical committee of diabetes under Health Ministry, where type 1 diabetes care improvement as well as for prevention of type 2 diabetes, both are part of that technical committee. So if I talk about the type 1 diabetes, before 30 years, when in 1995 as a second year resident, and we were supposed to take care of diabetes clinic, which was started by late Dr. O.P. Gupta, one of the probably first diabetes clinic in India. Maybe we know about Dr. Vishwanathan, but before 50, 60 years, he started a diabetes clinic, and simultaneously DCCT was published in 1993. I started my journey in the field almost same time. What over a period of time, something changed. At that time, only urine monitoring was there. Some of the young doctors will not able to know that only urine sugar people used to get, or the blood lab, you can send the blood in the lab to get your glucose level. And on that, we used to change the therapy. Now today, if I say that, just one random blood glucose level, you are thinking that patient sugar is uncontrolled. It was not like that. That DCCT, HbA1c had come, and in our medical college also, in our civil hospital, we were having a lab which was having HbA1c because it was World Health Organization supported, which was under a grant by Dr. O.P. Gupta. But to get HbA1c, you have to write a special, a letter, why you want HbA1c for this particular patient, and then head of department and HOD, everyone has to sign to get the HbA1c, that sort of things. Urine ketone strips used to come. Very occasional use of self-monitoring. Some patients, NRI, because Gujarat is a dharti of NRI, non-resident Indian, we used to get some patients who used to come with some self-monitoring of blood glucose, but for us in our department, only one glucose meter was available, which we can do only for hypoglycemia. If sudden emergency come, A1C was not for everyone, regular follow-up was not there. Even 300 patients we were seeing, no computer, no data, no records, no data, and nothing like an annual screening. So DCCT was published. I am talking of after DCCT, this had all happened. But I can say nothing has been changed in last 30 years in public hospital, except insulin was available that time also. We now also give under Gujarat government scheme, the tertiary care hospitals, insulin are given. Only difference is now we get A1C, and our patients are mostly given self-monitoring of blood glucose, whether they monitor 2 times or 4 times. So nothing has been changed as far as care for type 1 is concerned in last 30 years. In 2021, this data, before that, when this data was published by IDF, people were not thinking that type 1 is a major challenge for us. Even the Western world, when you go in SPAD, and when we had shown that no, we are the one having highest number of type 1 in the world. Not only highest number, we get 24,000 children every year added in this list, which is also very high. We are the number 1 in the country world having highest number of type 1. Yes, incidence wise, we are not number 1, not even top 10 country, but we have very high number of people with type 1 diabetes. Our incidence case is definitely low. This DCCT trial, I am sure all of you must have gone it multiple times. We all know that tighter the glycemic control, less and less complication. And there is no doubt about it. And I don't think we had to redo this trial again. We all know that DCCT well established. But at the same time, to achieve tight glycemic control, there was a lot of hypoglycemia at this rate. And probably we Indian physician read more about this red line. The hypoglycemia was more worrisome point for us rather than this tight glycemic control. This green line, we read less and we were worried of more of hypoglycemia. And that's the reason. The HbA1c before 30 years for type 1 was 9.5, 10, and still it is 9, 9.5 and 10, and we could not achieve a tight glycemic control. After DCCT trial, Actually, before 35 years, in US, the post-DCCT was there, addict. They were just trying to follow those people who were already in the DCCT trial. And what they done, that those who were having DCCT trial in the intervention arm, actually their HbA1c slightly increased, because now instead of 7.3, they were not under tight glycemic control, their A1C increased. But the conventional arm, they improved. The reason was very simple. They understood the importance of tight glycemic control, and they understood the importance of self-monitoring of blood glucose 5, 6 times, 4 times, 6 times, taking multiple time injection, and they improved on their own. I mean, definitely the doctors were taking care of them, and their HbA1c from 9.5 to 8.2. And this is the data which I am talking of post-DCCT 11 years. So I mean 1993, it was 6.5 years was over, and then after 11 years, it was in 1994. So I mean, they could improve just by seeing the data of DCCT trial, and their all physicians started treating their patient intensively, but probably we had not seen the DCCT data properly, or either we could not improve the care for our diabetic patients. They have done also 30-year follow-up. In 2016 data had shown that intensively control gives them lifetime control. I mean, better as far as complications are concerned. They get less complications throughout the lifetime, and they get even less cardiovascular disease too in type 1 diabetes. But I wish that my type 1 diabetic patients develop cardiovascular complications. If someone will say, what you are saying that your type 1 diabetic patient should develop cardiovascular complications, why you are wishing for it? I say that they should survive for 30 years. I wish that they should survive for another 30, 40 years and let them have a cardiovascular disease where we have a treatment. But today they are not surviving for another 30 or 40 years to have a cardiovascular disease, and we don't have that type of data. And I was just talking today morning with Dr. Rajiv Chawla that now to go to sweet registry, sometime it becomes, we feel bad, shy that our data is still showing. We have from India 12,000 patients data which we had put with the different centers, now irregular, my own data of 1700 patients, and we find their HbA1c is still more than 9. So actually speaking, this is the inconvenient truth that 80% of our patients have HbA1c of more than 8. Still we get 1/3 of our diabetic patients type 1, they get diabetic ketoacidosis, and this is fact. We get also hypoglycemia too, and definitely if they are long-term survival, they are going to get cardiovascular risk too. Now, why this happens? This is something very interesting data which shows that in first 10 to 15 years, whether you are treating someone intensively or whether you are treating someone conventionally, it means just 2 shots of injection, maybe one time a sugar monitoring will not make any difference because there will not be any complication. I had also published my own data because I am collecting the type 1 data since last 1998 I have, and we have published the data of 10 years, 15 years, 20 years, 25 years, what happens to them. We call them patients, those who are not coming, what happened, some of them are dying, some of them have died, some of them have complication, and we had seen that first 10 to 15 years in a type 1 diabetic patient, you will not get many of them developing any complication. And this is also the reason that we are not intensively treating. We mean the primary care physician, pediatrician, a physician, a diabetologist. If you have seen some patient newly coming to you, or maybe after 5 years somebody had started him on any therapy, you want to treat him intensively, patient is not ready because he never understands the importance of tight glycemic control, because his pediatrician, his primary care physician, in his lifetime, they never see a type 1 dying of a complication. It is only an adult diabetologist who see someone developing type 1 diabetes at the age of 10, and today he is coming to you at the age of 30 with nephropathy, with retinopathy. So that's the reason most of people are not very intensively treating type 1 diabetes. I always ask the patient to, the caregiver also, that what is the goal of treatment of type 1 diabetes? It is just definitely by giving injection, you are increasing the survival. But also, what you are going to do with the increasing survival, maybe for another 10 or 15 years or 20 years. Unless you have a tight control, it will not have a good survival rate for another 30 or 40 years. Diabetes management is not just in your clinic, which you are doing only for 15 minutes in a 3 months or maybe once in a year if you are a very senior diabetologist and seeing only tertiary care patient. But actually for patient, it is 24/7. It's a constant juggling between a diet and exercise and a lifestyle and insulin for everything. It's a constant juggling. This is an old data from Germany. It is again from sweet data which we have taken before 10 years. And this data shows that more the number of bolus, you achieve a better control of A1C. It means more the number of times you check your sugar and more the number of times you take the bolus either for correction or you check your carbs, how much you are eating, probably then and then your HbA1c is improving. So anyone who is in the range of 2 to 4, and I'm sure most of us, we don't write more than 4 shots in a day. Not more than 4 shots I had never seen in India, but ideally it should be 5 to 7. That is what the median number of a type 1 diabetic patient. If it is less than that, probably his sugar will never be under control, and he has to check sugar also the same number of times. That is what. Why I am showing you the older data? Because now in Germany, none of them is on these multiple bolus. They all are on pump and they all are on CGM. So now they can't have the data. This is all 10 years older data which I am showing. This is what DCCT chair told. If your patient comes with a HbA1c uncontrolled, just by increasing 1 or 2 units here or there is not intensive control. So intensive control does not mean that you are giving more insulin. Intensive control means you have to give more education. It's like a half a day of your time or your assistant or your associate or your educator, your dietitian, your social worker, your type 1 educator, they all have to work for educating that person and caregiver for improving care, just not by increasing the insulin level. And this is how a child has to survive with a multiple shots of insulin injection throughout the lifetime. This is like a 1460 shots is a minimum for that. This is one paper which we have written for type 1 diabetes awareness management challenges. This is 15 years back. Still the challenges are same. We still fighting with the government. We are very happy that Rajasthan government had initiated a project for type 1 diabetes. All district hospitals are going to have. In Gujarat, we are already discussing. Some of our tertiary care hospitals started giving free insulin. We are also going to have Saturday type 1 clinic in some of the tertiary care hospital, and probably that will be soon announced too. But this is the data of 2022, type 1 index. Very interesting paper. I think all of you must read it, and there is a website also, type 1 index. If someone develops diabetes type 1 below the age of 10 years, which as I told you, very high number of people in India are developing type 1 diabetes in children, they have roughly good quality of life between 15 to 20 with mean of 18.7 years. It means up to 28.7, they may survive. With a good quality, may not have complication. As I told you, first 10 to 15 years, most of them, they don't develop the complication. But what happens later on? Either they develop 4.5 healthy years are gone for complications, and then remaining life may or may not be there. So most of them will die. So normally they will not survive more than maybe 33 or 35. So in early 40s, most of them will die. And this is the real situation. We get only 1 or 2% of the people who are surviving, and there are data to show that in India, if you just write, because I have done this experiment also in 2022, we have done one experiment that how many people in Ahmedabad have type 1 diabetes who develop in their early age, and for 50 years. So we have done an advertisement in a Gujarat Samachar. If someone have a type 1 diabetes who is taking insulin for more than 50 years, we want to felicitate him. And that was the World Diabetes Day, a program which we have done. And we could not get a 1%. That was the fact. We can have, someone may say that Patel Sahib was there, and he may say that I have one patient who had survived for 60 years, and you may also say that I have one patient who had survived. But that's rarity. It's very, very less. And that's what someone may be very lucky to have it. But otherwise, this is what, and this is data is very recent in 2022. And how India looks like. We and Sudan almost look like same. So we are saying we are the 5th largest economy. We are the world fastest growing economy, and we look like Sudan. India and Sudan, no difference. The reason is very simple. As I told you, first 10 to 15 years, there is no difference. So whether you treat him in Sudan or you treat him in India, there will not be any difference because you just give insulin. Patient should not develop decay. That was only requirement. And for first 15-20 years, a person can survive in Sudan also, and he can survive in India too. So there is maternal mortality rate is considered as a part of your, that whether you are a growing economy or whether you are a grown-up economy or you are a very economically advanced economy. But unluckily, this type 1 mortality is not considered. And when we were having the first meeting in the government with that, I asked about that we should try to include this. Like maternal mortality rate is decreased significantly. We have perinatal mortality and neonatal mortality in our country is decreased significantly. Now each and every neonate died anywhere. There is a full investigation why it had happened. Or during pregnancy if someone dies, or during delivery if someone dies, say huge there is an investigation, but this never happens for type 1. So this should be considered as a part of that whether we are improving or not. Why does India look like this? Probably this is one very important reason that people are starting and giving them premix insulin, thinking that it will not cause decay, neither it will cause hypoglycemia. Patient is happy, caregiver is happy, doctor is happy, none of them develop any problem. But if we just change it to basal bolus, we have done last year in Diabetes India a national campaign that put everyone on basal bolus, and that's what in a type 1 diabetes conclave, which we have done the meeting last year in Jaipur, this year in Kanpur, and we are just trying to explain everyone that at least you do basal bolus, ask everyone for a self-monitoring of blood glucose, multiple times sugar, check it, educate them, and probably you can give them a good quality of life for a long period of time. The management of type 1 is not changed. I'm sure all those in Harrison, these 4 points are written: basal bolus therapy, self-monitoring of blood glucose, education, and regular follow-up. Only 4 things, nothing has been changed, no debates. Debates are constantly for type 2 diabetes to give GLP or SGLT2, this or that, multiple time debates, nothing has been changed in last 40 years. These 4 things, Ratilo, Gokilo, nothing is changed. Still we are not following it. This is what the challenge is. When Dr. Sadikor was there, in 2017, this paper we have written from Southeast Asia. And the situation in Southeast Asia is same. Today, why I am showing this paper, being a Southeast Asia chair, I thought let me share this, that it's not like that the India is not improving. In Southeast Asian countries, in Asian countries, except Singapore, Dubai, Qatar, and some of the developed countries, the situation is same. So in Asian countries, the same situation what we have here. The challenges are low awareness, misdiagnosis, availability of specialists, and availability of technology which is there. And we will discuss all these things. But where are we going? This is something which really changed India. I was part of SPAD Advisory Council in 2011 to 13. I asked that we want to do the SPAD meeting in India. They told no, in developing countries we never go. We never go to country like India where you people are not treating even the people properly in type 1 diabetes, and we can't have an international society meeting there. After 5 years of my fight, I could get this SPAD meeting in India. It was in Hyderabad. And it had really changed the way we were thinking. For 15 years we were fighting for all the time in the meetings, but in 2018 after SPAD we became the part of Sweet Registry. I can show here also the Durvi, Myra from my team, myself, we were part of this and we became the hub for Southeast Asia. We became the part of SPAD guideline. We became the part of SPAD guideline every year from 2018 to 2025. You see and go and see the SPAD guideline, you will find 10 doctors from India are now the part of the guidelines. It means we are following these guidelines and we have become the part of these guidelines also. But technology really changed. If you do self-monitoring of your patients, maybe doing 4 times in a day, if you put him on a continuous glucose monitoring, things are changed completely. So after 15, when we had CGM also in India, suddenly we started thinking that no, this SMBG is not working. Even we are asking the patient to 4 or 5 times, but it really actually having multiple times hypo and hyperglycemia too. So do we have evidence that CGM is gaining work? Yes, in type 1 diabetes, we have done our own data also. And this is the data which is after 25 years. It had shown that in DCCT, it had shown 62 per 100 patients here hypo. Significantly decrease hypo by 20. So not only it improved HbA1c, if you put the patient on a CGM, on a type 1 diabetic patient, there is a significant decrease in hypoglycemia and still they are achieving better diabetes control too. We are the part of this continuous glucose monitoring as an international consensus with some of the world authorities. Even we were not having so many people on CGM, but still I was included in this and it had become a complete new, this paper had really changed the way we were treating diabetes. Because before that, we were chasing the HbA1c, and then later it had become time in range. Again, in 2019, all over the world, people have started talking about time in range, because HbA1c gives you information about last 3 months. It does not give you any information that what is going to happen in next 3 months. It just gives you your 9 HbA1c, mean your 9 HbA1c of last 3 months. It does not give you any information what you are going to happen in next 3 months. It is time in range. Every day you check your sugar, continuously you monitor and try to achieve your sugar between 70 to 180. That is going to make the difference. And no hypoglycemia. It is for type 1, type 2, and all over the world people is accepted it. But there are challenges again with continuous glucose monitoring, particularly for type 1 diabetes. And you must have seen many of your patients, putting them on CGM rather creates more questions than answers. The same patients may have 2 different days with the same lifestyle. Middle of the night, I'm not talking of something in day, he might have changed his lifestyle, but middle of the night, one day sugar is around this, another day it is like this. One day it is 90, other day it is 200 plus. So you are more confused than what you do. You know this patient whether to increase the dose or decrease the dose, what you will do. And that requires something else, because patients may have multiple time, different type of sugar report, same patient with the same lifestyle, and these patients require something more. But do we have data? Yes. As I told you in 2019 when CGM became the standard of care, then they had come out with a time in range. All over the world, people started for all type 1 diabetes. All insurance company, government, NHS, National Health Service, all type 1 should be on CGM. And this is the data in UK. They found that putting the patient on CGM is actually not achieving tight glycemic control. They were not able to achieve HbA1c less than 7. Yes, hypo rate significantly decreased. They could decrease their HbA1c, but still the patient sugar or time in range was not 70% all the time. And this is, you must have also done for some of your type 1 diabetic patient. Putting them on CGM will not able to get time in range for that. And that's what the pump is required. You can put multiple bolus and you can put multiple basal dose for the patient. So I mean, the same patients can put the pump and having a multiple basal dose and multiple time bolus dose can be there. This is one paper which we have written about the practical issues. One definitely a practical issue will be cost, which we will discuss during tea time. But insulin delivery device proved over a time, and this is after 2019, the time in range concept, that pump is the only standard of care, that is A, and what we are giving is insulin syringe is actually C, evidence C. So I mean, this is before COVID, the diabetes care, American Diabetic Association for type 1 diabetes, it is sensor augmented pump is only standard of care. So do we have data? Yes, in 2016 they have proved the data. Not only they have achieved the HbA1c from 7.7 to 6.9, but hypo, which was 62, which had decreased to 20, it had become 0. It had become 0 because that you want, because we were worried of hypoglycemia in DCCT trial. Now without hypo and still achieving HbA1c of less than 7. So if you have your patients, maybe out of these 4 variety of patient you may have, the patient who are on multiple daily insulin injection with blood glucose monitoring, some of your patient may be using CGM, some of patient may be on pump, some of patient may be on sensor augmented pump. But if you do their continuous glucose monitoring, you will find that none of them are actually achieving time in range more than 70%, and that's what the standard. That's what you want your patient not to go in hypo, and you want them to have more than 70% of the time. And this is what an advanced hybrid closed loop system is the only answer for the people who are type 1 diabetes and they can achieve a time in range. And we were top 10 centers, actually top 5 centers in India who had put highest number of insulin pump, and we were the one of them center from Gujarat, and from all over India, the 10 centers we had put 1500 patients on this advanced hybrid closed loop system. And this paper which I have written, and it has been published in last ETTD, last month only in March, that call to action. I was the first author for this, that standard of care for glycemic management for youth and adults with type 1 diabetes is an AID system. Even going from the developing countries, not putting so many patients on pump, but I included all those experts who were part of the time in range paper or that CGM paper, where I was also part of them. I invited all of them that I am writing it, and I have written that all people with type 1 diabetes and other insulin deficient diabetes must be given a choice. I mean, it's not necessarily that he is buying or he is taking, but at least you explain. As a doctor, it's your ethical duty that this is the therapy which is available. At least you show him. If patient is not affording, not able to take it, write it, document it, like we are writing a heart failure patient. If you are a patient of heart failure, you are not able to write SGLT2 therapy, you write somewhere that this patient is having infection, this patient was having some issues. Write it. At least you document it. That is what we want it. Definitely this type of documentation will help, because somebody will say that why you want me to write on a documentation. This will help us to talk to government. This is what required. This is that each and every doctor is writing that this is must. And this is same thing your cardiologist friend had done before 25 years. That each and every patient need angioplasty. Before 50 years, your ophthalmologist friend had written that in cataract patient, the surgery is required. They have written it. Patient has not taken. They have not gone for cataract surgery, but they have written, and today it had become mandatory for each and every cataract person to get surgery, and government is doing free of charge. Before 30 years, knee replacement surgery started writing. Patient requires knee replacement. Patient may not go for it. And this is what I thought that we should write it, at least document it. And I'm sure in coming 10 years, we will get that government will be providing insulin pump to everyone. What will be the future? So we stopped here that in recent past, this is the immediate what you can do best for your patient. This is what the pump is like, a artificial pancreas. But ideally what we should do, we should try to cure it by restoring insulin production. And that is what the cure for type 1 diabetes. As I told you, probably after 10 years, we will not be talking about those technologies. We will be talking of, there is a cure. Now, a type 1 diabetes, it will be a cure. But at present, there are challenges because cell source is an unlimited source of beta cells you need. You need cell survival, because if you are putting the cell inside, again it may die because of autoantibodies, and then you have to protect those cells by some immune system, by some immunotherapy. That is what is required for that. It is there. Cell source stem cells have therapy. Islet cells are already there. And there are challenges, definitely. Immune protection is there. How you can immunely protect? You can put the beta cell in a capsule form, in encapsulation. You are putting it in such a way that your own autoantibody is not going to destroy those beta cells, or you have a locally targeted immune modulation. So you're putting those beta cells and they will be modified in such a way that your immune system will not create them, or they will not destroy it, or they are gene editing in a genetically modifying in such a way that they will get protected by immune system. Recent advances, it is already there. Lentidra is there last year in ADA, those who were there. This was already presentation. US FDA had already approved. It is already available. Beta cells by one company, it is available. And the problem is, at present, they don't have the significant amount of beta cells which can give to all over the world. It is available, US FDA approved it, and it is already there in the market. And these are some of the companies. Vertex is one company who is producing it, and these so many companies, 6 or 7 companies. There is one Chinese company also. So it means all over the world people are working on it, and there will be beta cells which will be available to us. Maybe in another 5 years, maybe another 10 years, we will have the people with immunotherapy, with beta cell replacement. One very important thing is that we diagnose type 1 diabetes maybe at this stage. If you can diagnose someone at this or here. If here, definitely you can prevent. Very difficult. Italy, we were discussing, Gurvi was also there, people were also there. One of the doctor Italian in the suite registry, they started doing for universal screening for all children at the age of 2 to 3, at the age of 5 to 6, at the age of 11 to 12. All Italian young boys, young girls are screened for autoimmunity. They have point of care testing now, autoimmunity testing. If you can detect someone here, or here, you can give them an immunotherapy. But definitely if here, it can prevent. Me and Dr. Sanjeev Phatak have done long back a study on a teplizumab, which is now available. And we have done that. It's an immunotherapy. We never thought that it will work. It was at that point of time, because in India, we could not diagnose the people early. It was indicated at the time newly detected diabetes patients, you start giving them. We were having few patients also. So early detection program is already going on there. In Italy, it is for universal, but for other countries, the high risk, and definitely they are calculating also who should be given. How many different disease modifying therapy? You will be surprised. These therapies are available. Already this is available in the market. These are the 7 disease modifying therapies showing preservation of C-peptide following 1 year of treatment in stage 3. But if you can diagnose people at stage 1 or stage 2, probably you will cure them for next 10 years, 15 years, 20 years. The things will change. Costing almost 1 crore rupees in US. It's for rare disease and it's available already in the market. But will it be available to India? Yes, it will be. If you will be thinking of that, yes, type 1 diabetes can be cured. This is what a novel is. This is anticipated maybe in few years. This is the last slide. There is one more oral therapy which is going to come. It is nothing to do with the beta cells. It is going to work at the hepatic level for type 1 diabetes. They are thinking of that they can control an oral once daily therapy that targets liver to improve glucose control, and they are targeting and trying to do only for type 1 diabetes. This is what the study is going on. It is in phase 2 trial. So the clinical care for type 1 is changing. As I told you, the recent past, at present, I will say the past is pump. That is the best thing available. Today, if someone come and ask me what the best thing which I can do for my child, I tell that it's only insulin pump, which is the best thing which you can do it. But today or tomorrow, maybe a disease modifying therapy we will be giving them, immunotherapy, or someone have diabetes, we will think of giving beta cell replacement maybe after 5 or 10 years. To conclude my talk, DCCT insights remain critical in shaping type 1 diabetes care. I don't think there will be any other DCCT. We know about DCCT. We need a national-wide type 1 diabetes registry. Addressing gaps in affordability, accessibility, and awareness is essential. Expand subsidies and healthcare coverage, and that is what we are trying to do in that national government program. Enhance public awareness and reduce stigma. I always say that someone say that why you don't want to put your patients on pump, and pump is very costly. I always say that even those who can afford, please give them. They may be 10% of your patients. You may have 100 patients, out of them 10 you put. Because they 10 will change the way we are treating diabetes. Today, if you are going to give only 10 patients, they will become tomorrow doctor. They may become politician. They may become IAS officer. You know, so after 10 years, 15 years, 20 years, things will change. If you will not put anyone, none of them will survive in their 30s or 40s. So, I mean, it's our duty at least give to them, those who can afford. Things will change definitely. Leveraging policy reforms, innovative technology can transform outcome. Scale up AID, CGM adoption. India has potential to become a global model for managing type 1 diabetes in resource constrained setting. I was just talking, Pratap, that people call me to give a talk only on this thing because we have from poor countries what they can expect. We can't talk all these things, new thing. We listen, but we talk about that what disparities which we have in our country. To know more about technology, we have a dedicated meeting which we have started. This is 4th one, and we also started a dedicated meeting for type 1. These are the 2 meetings which I founded that let us have more technology in our country and let us improve care for type 1 diabetes with these things. I always say that it's better to be more equitable rather than inequality. We doctors always try to give equal care for all your patients. But some of your patients may require more education. They require more time. They are poor. They may require more resources. So be with an approach of equity rather than an approach of equality. That will help your patient and that will improve the care for our diabetic patients. I am thankful to all those supports by different international organizations who are giving, including RSSDI, which we have created a RSSDI type 1 diabetes network, and with Diabetes India and many more international organizations. Thank you very much.